say thank you for letting me be here for part of your IDM to help kind of explain the telehealth process we're going to for the evenings, holidays, and weekends. There were some trainings last month, but then we had some significant delays with being able to get the rollout actually going. So we're wanting to do a lot more trainings these next coming couple of weeks. Plus, she's recording so that it can be put into HealthStream so that anybody can have access to it. So everybody will be comfortable with knowing how to use the robot, what it looks like, which is why I brought it in here today. And then I'm going to go through just the flow sheet of it and all of the little forms, which I have them laminated and I keep them on the back of this machine. But I'm going to go ahead and pass these around. I'm actually going to be going over all of these sheets, but this way you guys can actually see them, look at them as I'm going through the demonstration. So I know there's been a lot of wondering, well, why are we having to do this? You know, why are we having to do this telehealth? Well, unfortunately, as you guys probably have noticed in the nursing field too, like there's always shortages. It's the same thing with behavioral health. It's historically, we've really struggled with being able to keep PRN staff that are willing to do on-call. You know, even after creating bonuses, incentives, things like that, it still has been very challenging. In my 2.5 years I've been here, we have been fully staffed twice. Once was for 3 months, the other one was for like 2 months. So that tells you it was, and then we had gotten to the point this last month, there was only 2 of us doing all of the on-call shifts. And so it just wasn't sustainable. So this is actually a model that is used by several hospitals in the state of Colorado. Even Family Health West also utilizes this. So it has been proven to be very successful, and it's a great adjunct piece of equipment that we have that can help to make sure that we're filling any gaps of services. Because right now, well, actually we are officially have rolled it out, but prior to the telehealth, we only had the on-call from 5 to midnight. It used to be from 5 p.m. till 8 a.m. in the morning, but that was even harder for staff, you know, trying to keep staff that would be willing to come in at 1 o'clock in the morning, be there for a 2-hour assessment, typing up notes, then going home, and then being back to work by 8 o'clock. You know, and again, it just wasn't sustainable, so then they tried moving it back to the 5 to 8, you know, so, you know, again, this is like historical over the past 14 years, like this was passed down from my predecessor and everything. So we have contracted with HCAT, so that's why you'll see HCAT Health One, that's on the documents here. That is the company that we are, you know, leasing. We lease this robot. So this robot actually lives in the ED. Do all of you guys know where the blanket warmers are in the ED? Okay, so next, for those of you who don't know, okay, do you know where the Sally Port is, where they bring people in with like the ambulance? Okay, so if you were to come in those doors, you will look directly at the warmer. Okay, and then right next to that is the telestroke machine. This is not that dissimilar from the telestroke machine. And then this sits right next to the telestroke machine. So it comes, all you have to do is, when you, say if you have to take it to ICU, MSU, labor and delivery, or any other floor that you happen to be on, you would just unplug it. It does have a battery, even though it'll say on the screen here, you guys are probably seeing, it says we need to plug in, because normally we keep it plugged in 24/7, but you can unplug it when you're moving it. And I'll have a sign in, sign out sheet so that we know like when it's taken out of the ED, like kind of who has it, where's it at, so that we can identify it if it's not in the ED. So now I'm going to go ahead and go with the workflow. I kind of shared with you the reason why we had to have it, we went with this option. And so now I'm going to kind of go through and explain the process and the machine. So this here, like I said, is a robot. You know, we can nickname him Wally if you want. He does kind of look like Wally, and the robot head does move. So like when the clinician gets onto the screen, they actually have a remote access on their end where they can actually follow. So in the screen, you know, right here, like for the nurses and stuff, when they are asking, what is the name of your machine? It is located right here in red, the care location, the SN number, it is right there. But once it's on, you'll see the picture of the clinician, and then a small box right here is that's gonna show the actual patient, okay? Now, at first I was like, well, let's keep that off, especially for our acute psychotic patients. As we know, sometimes we have those that, that are in active psychosis for schizophrenia or schizoaffective disorder. It can be very triggering. However, for some individuals, they would like to see that so that they, can see their face. So we have decided to go ahead and leave that up to the clinician. They have a lot of experience of knowing if that is triggering for the patient, then they can shut it off on their end, okay? So you really won't have to do anything except for this being moved into the room. You're not gonna have to really touch anything on the screen, just move the machine. So this part you won't have to worry about this being, I don't want you guys to feel overwhelmed seeing this robot. So this right here is the start of the flow sheet, and this is in the order. I sent this in an email. It's in the same order as the ring of pamphlets going around. So what will happen is if there is a patient that is in crisis and needing a behavioral health consult, whether it's in the ED or labor and delivery, ICU, MSU, short stay, what they will do is we will have the charge nurse, or we will have just the attending nurse for that patient call HCAT, and they'll call this number that is the 844 number and press option 1. So you'll see I put in like big bold because we did have a struggle with the first initial consult we did. There was some struggles with it because they accidentally on their end sent it to the psychiatric part, and they were telling our staff, you're calling the wrong number. This is the correct number, so I went and made sure we kind of like bolded when you call, state that it is for a behavioral health consult. That way they know they don't need it to go to a psychiatrist. We're just needing a behavioral health, a licensed clinician that is able to meet with our patient. Okay, so when that first call is made, that's gonna trigger that they have a consult coming, okay? So that kind of starts our clock. Now, the initial consult won't happen until after blood work has been sent, because they're gonna want all of your, they're gonna want, as you see there, when you call, let me backtrack. When you call, they're gonna wanna know the facility name, the RN number and name to call back on, because they're gonna contact that person to say, hey, we're ready to go, let's get the robot in the room, and that way we can get that started. So that's why they need all of that information. They're gonna wanna know the attending doctor's name and their callback, the patient's name and gender, patient presentation, and then again, that robot name, the SN number that I said is right here in red. And they may ask for additional information, but key thing, say behavioral health. So like I said, that starts the queue. Now, it can take anywhere from 60 to 90 minutes for them to do a callback. Okay, in the ED, if you tell them you're in the ED in the emergency room, and I know most of you aren't in the emergency room, but I know sometimes you float there. That's why I'm going ahead and just sharing this general knowledge. So if you state that you're in the ED, because that does put it as a higher priority. So with that, they say that they're gonna do the consult within 60 minutes. Okay, so if by chance, and I even put a sticky note back here, if by chance, like say you haven't heard back in an hour, call them, see if they're missing something. Because that should occur within that time frame of that 60 to 90 minutes. But before the consult can occur, what they're gonna need is they're gonna need the face sheet. Now some of you are like, what, M1 and rights, what does that mean? So I'm gonna flip over to, and I'll go back to the workflow, but so for an M1 hold, that is for a psychiatric hold. So if we have said we know we're putting them on a psychiatric hold, they came in, it's definite, it's clear that they meet criteria because they have, say they have homicidal intent, they've told you they have a specific person that they wanted to kill, that they had the means to do it, that's qualifications for an M1 hold. For mental health, if they're saying like they're suicidal, they have a plan to commit suicide, then that definitely is meets criteria for the M1 hold. The gravely disabled can be a bit more challenging. That is when it's really somebody who is beyond their baseline. So, and just because I looked at you, Megan, I'm sorry, I'm gonna pick on you, and now you get to be in the recording. So let's say Megan comes in, and we know Megan, and all of a sudden she comes in and she's just like hyperactive. We know her UDS screen comes back completely clear, but she's just like moving around crazy and talking frantically and saying how she just maxed out all of her credit cards. This would not be our normal baseline for her. So that would tell me that this person is getting to that point of being gravely disabled, and it's impacting their daily abilities. And, when you max out all your credit cards, that has those catastrophic, things that can happen from there. So that would be like an example of gravely disabled. Somebody who is not at their baseline. Sometimes we'll get our acute psychotic patients who have decided to stop taking their meds, so then they are either extremely manic or they're hearing they are the Archangel Michael. I've had that happen too. So that would be something that is definitely grossly disabled, where they're really just not cognizant and aware. Now there's a difference between baseline feeling those ways and where it's out of their norm, where they're not bathing, showering, doing those things because they're in such an acute psychotic state that they can't take care of themselves. So in that piece, then we would make sure that we have, this is one of the forms that are filled out. This is where we're just initialing it. So you'll initial if the emergency hold form was filled out, initial if the patient rights were signed, and I'm going to show you what patient rights are. And the reason, and then you will just put your initials and signed, because all of this documentation can be found in Forms Fast, but also the originals, they have to go to the receiving facility, which is one reason. And then plus the HCAT needs it for the part of their evaluation piece. This right here is the actual M1 hold form. And again, the cleaner copy of this, because of course this was an email to myself, can be found on Forms Fast. And so this would have to be signed by the physician. And it's very important that it's filled out very correctly. So like for example, one time I made a mistake and I wrote PM instead of AM. And so that made this whole M1 invalid. So I had to go and rewrite it out because they don't want scribble marks or anything on there because they can't accept that. So I had to go and rewrite the entire form, to make it work. So it just needs to make sure that it is filled out correctly. And this part where you write the detail information, you're checking and identifying whether they are gravely disabled, they're danger to themselves or others, and just a brief synopsis. So for example, so since I had already picked on Megan, we'll just use that example. Patient reports, maxing out all of their credit cards in the last 24 hours. They are present to be in a manic state. They state that they have not slept in the past 3 days. This is not their norm. They have never been previously diagnosed with anything. So something just very basic, simple, that explains what is the justification for the hold, okay? And then when they're talking about the rights, so when we put somebody on an M1 hold, we are taking away essentially a lot of their rights. And so it's imperative that the nurse will go over, read these patient rights to them, and trust me, there are times where they're like, I don't want to hear this, and they're like, oh, covering their ears. You're like, I'm sorry, but I still have to read them to you. And if they're not agreeable to the telehealth at all, then of course, then we would go to, okay, we'll just hold them here in the ED or something till Crystal comes in the morning and we can do an evaluation. But usually by this point, they've started to calm down and you're like, well, I have to read them to you anyway. Then usually what I have found, they'll calm down and let you read it to them. Because they do have basic rights. And that's why when I've had nurses say, can that person have a telephone? So in their rights, and so I'm not gonna go through all of these verbatim, but in their rights, they do have a right to telephones. They do have a right to, but if they're safe, if you're, I wouldn't recommend having a phone with a cord or anything. We have the cordless phones at, all of the nurses' stations. They can use a cordless phone. to make a phone call if they don't have their own cell phone, okay? But if, like, say they're very amped up, they're throwing things, then of course, you know, for safety reasons, we're not gonna let them have their phone. And we can use that as a, you know, once you're calm, then I'll be happy to bring that phone to you, but we really need to make sure that you're safe. So this kind of helps to understand, you know, why we say yes, that they can have the telephones, because it is one of their rights, okay? They do have right to clothing and possessions. However, we do have a policy at our hospital that supersedes this, so that's why I always let them know when they go to their facility, they will be able to have their own clothing. However, in our hospital, our policy is the paper scrubs. Now, we can make exceptions to that because our paper scrubs, they only go to a certain size. And also, sometimes I've used it as a bargaining chip to get them to be able to talk with me. Okay, you know, if you promise you're gonna be safe in wearing the gown, we'll have to ask for your shoes, you know, but let me talk with the doc, see if he feels comfortable with that, and, you know, and then we can make that exception. And then you would make sure, of course, that's documented, that you use that as a tool to help, you know, make the patient feel more comfortable and everything like that. So those were just a couple of the ones that I know that come up a lot that I wanted to talk about with the patient rights. So now going back to the workflow. Sorry, I know it's a lot of information, which is why we're recording it, so that way we'll be able to give it to you guys so that you can review it. So anyway, so if we have already done the M1, we know that they're on it, we give them those patient rights, we fax that over. We're also gonna fax the UDSs because per our rate, especially for Medicaid, they have to have a BAC of 0.08 or below in order for them to be able to be transferred to a facility, be accepted in a facility. So that's going to be one of those requirements. So, you know, and as we know, sometimes that BAC takes a while to come down, and we do have some people that come in with very high BACs. So you'll send all of that in the doctor's notes, and if there's any nursing notes, over to them. But like I said, if you have not heard back from HCAT, within, if you're in the ED, if you have not heard back within an hour, call them. You know, if you're on any of the other floors, call them back, still call them back and say, you know, where are we at in the queue? Just wanted to make sure you have everything you need, okay? Because I don't want any issues of like, well, we never heard back, it's been 3 hours. You know, we want to make sure that our patients are getting that care that they need, okay? So then from there, once the consult is ready to begin, what we'll do is they will contact the nurse, like I had mentioned. You're going to give them this SN number, and then you're going to take this into the patient room. Now, we can have security or CNA, a sitter, sit in the room. This is all going to be part of the telehealth policy I'm working on right now. We're going to try to get it expedited so that it'll be in Lucidoc. My goal is to get it finished by the end of the day today, at least the first draft, you know, because of course it takes several drafts and has to go through legal and everything. So, but at that point we can have just somebody sitting in the room, because we don't want to leave this expensive piece of equipment in a room with somebody and have it destroyed. And right now we already have sitters or security sitting in the rooms if somebody is, you know, says that we feel like they're a danger to themselves or others. So then what they will do is, after that is completed, they are gonna fax back their documents of their assessment. And then if they meet the criteria for inpatient hospital stay, that HCAT will be the ones to seek out that hospital placement, okay? And they're gonna start out with the closest one first, which is West Springs, excuse me, and then they move out from there. I am going to be talking with them because, as we've found out recently, West Springs has closed their adolescent unit, which means all adolescents either have to go to Montrose or they have to go to the Eastern Slope. Montrose only takes very low acuity. So if you've had a patient, somebody who's underage who has had multiple suicide attempts, they're going to be too high acute for Montrose. Because of the work I've done, I already know that. Or if they're on a lot of psych meds already, they're going to be too high acute for them. So the barrier with that is you know, we have contracts with Guardian and Citadel. Well, they'll do the transport over if, like, say they don't have Medicaid, you know, so that's all part of the billing process. We contract that out, but then they don't have a ride back unless family goes. And as we know, that could be a barrier for some families. Either they don't have a car, or, you know, they can't travel to pick them up. So Centennial Peaks has merged with Highlands Behavioral Health, and they will help them get a ride back to the Western Slope. So that's why I'm going to be contacting HCAT, that if it is an adolescent, that we make sure that those are kind of like the go-to clinics first. And they are also really willing to work with us. Like, say a consult happens at 1 o'clock in the morning, but we know that placement can't occur, or the pickup can't be arranged till 8 a.m. the next morning. They're okay with saving that bed, holding it open for us, because they know the barriers that we have on this area. So they're really good about that. So, so then that would be the end of your workflow, you know, for all of that. And I usually put all of the, and I can actually, now that I'm thinking about it, what I'll do for everybody is I have like a little flow sheet of, like, for the M1 hold packets of what has to be in there to go with the facility. I think what I'll do is I'll make a mock envelope and have that on each floor so that you guys can have that for a reference as well. Because I know I gave each floor a folder with all of these documents, just in case you can't find them in Forms Fast. You can photocopy them, it's okay. Plus, you can always photocopy these if you need to. I've made sure that they're going to be highly accessible to everybody, okay? But yeah, so I'll do that with the folder, and I'll get those to all of the floors too. And so that people know exactly what needs to be in the folder to be handed over to Citadel or the Guardian. So the next page I have on there is, I went on ahead and just wrote this up just to kind of help explain again about the BAC, and then also kind of explaining why we have to have the BAC at that level because of our array for our insurance out here. And then the other thing is they have to be out of restraints for at least 4 hours before they will even, you know, accept doing like a consult and stuff like that. So, which that typically doesn't tend to be an issue that we have. I mean, even if they had somebody who they had to give like a chemical restraint to, I usually don't do the consult until they're alert and orientated anyway. So, and then they will contact you back once they have found the placement. So they will have to fill, whoever's the nurse will have to fill out the MTALA. I know the ED has worked really well with me. Even MSU, I've had to call them, like, you know, when I would go home after I've sent out the referrals, and then I would maybe get the acceptance an hour later, I would call back and I would just report all of the information to the charge nurse or the nurse, and they fill out the MTALA. That's essentially what HCAT will do, is let you know who accepted, when they accepted, and then we would just contact the Guardian or Citadel, because we have contracts with both of them. And I have their numbers right here on that second page. Guardian, their numbers here, but I also know you guys have them in multiple areas on the floors, and then Citadel. And then I wrote here what needs to be in that manila folder to go to the facility, but again, I'm going to create a mock one for each floor so that you guys have that, and so it's in multiple different areas so you have that quick reference. I've already showed you the paperwork that has to be filled out with the M1, and kind of explained that has to be filled out absolutely correct, because like I said, I've had to redo them myself. This is the patient rights. Now, the other thing is before we can actually have the telehealth starting, okay, we have to have the patient sign the telehealth consent form. There in the ED, there's paper copies, and they've really labeled it nice and bright for telehealth consent forms. It's also on, should be up in fast forms now. It should have already been approved. It was already approved, and it's been a couple of weeks now, so it should be up there. So it's really just them agreeing to the telehealth consent piece. And like I said, if they decline the telehealth, then that's where we go to our old process, like in the ED and stuff, where we would say, okay, well, we'll just have them sit here. We'll wait till Crystal gets in at 8 a.m. Now, if it's on a Saturday morning and we're like, we can't wait till XYZ date, give me a call. I'll make a run in. My phone number is at the bottom of the flow charts where if there's any issues, you know, I would prefer you go to like the house soups first who are available to problem solve some of this stuff, but if not, call me. I don't care what time it is. I may sound very groggy and you'd be like, Crystal, is that really you? Like, yeah, I even taped it right next to my bed, so in case anybody calls me and it's like 2 in the morning, I've got it right there that I can stare at it and look at it if my brain's not functioning. So, like I said, it's, I know this was just kind of down and dirty, you know, on all of the forms and everything. So before I conclude, do you guys have any questions? Do you feel like I explained it thoroughly enough? You know, because I don't want anybody to leave here feeling like I have no idea what I'm doing.
I have a question.
Sure.
How many robots do we have in our hospital?
We have just this one for the telehealth, and that's why I said it's going to reside in the ED, next to the telestroke machine and the blanket warmer.
I think the next question would be, we only have one robot in the whole hospital. When do we start getting that machine? Because we have to wait like 60 to 90 minutes. Is it right after we send all the necessary documents and we bring the machine to the unit?
Yeah,
or?
that would be totally fine to do that, even though you know that you're probably gonna wait a little bit, but this way, because you have no idea how long it'll be, because sometimes they might be really quick to get back to you. And if it's like, say, a blue moon or something out there, and there's lots of consults throughout the state, it might be a little while. Yeah, please, feel free, go down to the ED. I'm actually thinking the sign-in sheet might need to be affixed to the wall, because if it's affixed to the machine, we won't know where it's at, so. I'll get with, Sarah and see if she's okay with me putting the sign-in sheet laminated right there on the wall there. But anyway, so, yeah, you'll just make sure that you sign in of what floor you took it to, that way, and then once it's been returned, you can, you know, use that dry eraser, take the name off, and that way that's there. Yes?
Do we wait for the clinician to call back on the screen before we take it into the room, or when should we?
So they should be calling you as soon as they're ready for it to go. So that's when the machine will go into the room.
Okay.
And it's at that point where we can have a sitter or the security guard, because you know, we know that the, you know, consults, like I've shared, like me, as you know, you've all kind of seen me work in the rooms. Sometimes I'm in there for 20-30 minutes, and sometimes, like the last night, I didn't get out of here until 6:45 last night. You know, I was in, and I went in there at like 4:50. So sometimes they take a long time, and we don't want to take our nurses off the floor for that long. So we are okay with doing that, with having the sitter or because the sitters hear all of the stuff anyway. We're all bound by the confidentiality, and our security are usually in the room as well, or security or a sitter. Any other questions? Yeah.
This is just for the initial patient evaluation and assessment.
Correct. Yes, this is if like, so, and let's say it doesn't have to be just for an M1. Let's say it's on the weekend, it's Saturday, you have a patient that is like, you know, as we know on MSU, they're dealing with a lot of stuff, you know. I've already sat in one patient room with somebody who got this heightened anxiety, because a lot of times they're receiving some information that's not pleasant, you know, and so this can be just for a behavioral health consult, just plain behavioral health. If they can't wait till I'm here on Monday, it can be used for that, or it can be used for the M1. So it's not strictly for that. And like for labor and delivery, for those of you that aren't aware, labor and delivery, if somebody that goes into labor and delivery and they are age 19 or below, it's an automatic behavioral health consult trigger, okay? And that person cannot be discharged home until that behavioral health consult occurs. So that's where I could see labor and delivery possibly having to use it on a weekend, you know, or if like say they had somebody who expressed suicidality at night on the labor and delivery unit, then they could see them using it for that. But so please know, it's not just for M1s, it's for all behavioral health consults. I'm still gonna be here like Monday through Friday. I'm here like 8 to 4. I do like, my schedule is actually, I will take the calls for until 5 p.m. So even though like it's after my hour, if it's still, I get a call at 4, like yesterday, I got a call at 4:40.
I will still go and take that, come back to the hospital, take that call and do that.